Okay, we're good to go, Eugene, if you want to start.
Okay. Good evening, everyone. Mixing things up here a little bit. I'm neither Hamid Taheri or Sean Yazdani. My name is Eugene So. I'm an interventional cardiologist with Carient Heart Vascular. I'm really pleased to introduce our guest this evening. It's hard to believe that I've known Eric Osborne for 15 years, it looks like, Eric. Dates back to our fellowship when I was a fellow at Walter Reed in cardiology, obviously, and Eric was a pulmonary critical care fellow. Like me, Eric is a retiree from the United States military. We both are retired colonels in the Army. Eric is a graduate of Columbia University Medical School and did his residency and fellowship at Walter Reed Army Medical Center. After a really illustrious career in the military and multiple deployments overseas, Eric retired from the Army a few years ago and joined the Innova team, where he's really had an integral role as the director of the adult ECMO program. For those, I think everyone on the call, let me just scroll through, is familiar on some level with ECMO, but for those of you who are not, I tell lay people that it's basically like the highest level of advanced life support that someone could be on when they're in pulmonary or cardiac failure. So Eric has a wealth of experience in that field as an intensivist. And I think especially pertinent for today's topic is his experience in the past nearly 3 months with dealing with the sickest of the sick COVID-19 patients. With that, I'll start the discussion and just ask Eric to give us his sort of broad overview of what the experience has been like, what it's been like in the trenches for those of us that really haven't been on the front lines of the COVID fight. And please share any experiences or any information you have with what you've learned thus far. Thanks, Eric.
Thank you, Eugene. Can everybody hear me okay?
Yes, we can hear you.
See some nods. Okay. Yeah, thanks. And I appreciate the introduction. Yeah, I have known you a long time. I'm the medical director for adult ECMO, and Dr. Ramesh Singh is the surgical director, and then Alan Spear is the overall director. He's on the call, and he's been extremely supportive. Reasons we've been so successful. Yeah, we are just over 2 months into the COVID pandemic, and we've done 32 COVID ECMO patients along the way, and we're on pace. I'm not publicly talking about this yet because we still have 7 COVID ECMO patients that are still on ECMO, but we're actually on pace to have an 80% survival, which is ridiculous, it's incredibly high. To put that in perspective, if you look at our first close to 200 vented patients, all comers, that patients with COVID pneumonia that ended up getting put on ventilators, their survival is about 55 to 60%. So it looks like that at least our ECMO patients have done better. A lot of that is we kind of adopted a combat medicine selection criteria. And in combat medicine, meaning if you have limited resources and limited personnel, let's use our limited resources on the patients that are more likely to survive so we can get them back into the fight or get them back into the battle or get them back into society, playing with their kids and going back to work. So we selected younger, healthier people and had our selection criteria more stringent for lung failure. And I guess to go over, since this is a cardiology, I was actually going to be interventional cardiology along the way, and then went out and did 3 years of general medicine in Germany, and then ended up going into pulmonary critical care. And I guess now I do both lungs and heart. But for lung failure, ECMO has now been, just to back up, it's been around, been used successfully for over 40 years on kids and babies. It's only really in the last 15 years or so become effective and been used more frequently in adults. It came out of bypass surgery, which has been around a long time, but ECMO is a lot different than bypass surgery. Bypass you go on for a couple hours. It's a complex, much different circuit. Your ECMO patient for lungs, the average is going to be 1 or 2 weeks on a consistent miniature heart-lung bypass machine. For VV ECMO, it's really reserved for people who fail the optimal evidence-based therapy. And as you all know, we are naturally a negative pressure breathing machine. So right now, as Eugene is sitting there trying to stay awake while I drone on, he breathes in and his pleural pressure is actually negative. He inhales his pleural pressure. If I could measure the pressure inside of in his alveolar space, it's negative 5 centimeters of water. And then he exhales and it comes up and it's 0 or +1. So our natural state, our normal physiology is negative pressure breathing machine. That's how God made us, or Providence made us. So what happens when the lungs get sick? Well, we've been giving them positive pressure, and that's putting a tube in the lungs and blowing air into the lungs. And we've been doing that for 53 years since ARDS was identified back over 53 years ago now, I think. And what do we do when some positive pressure doesn't work? We give more. So they turned up the ventilator, they turn up the pressure, they turn up the volume. The microprocessor technology has evolved faster than our ability to study it. So what that means is the ventilators became computers, and we had developed different ways of giving positive pressure at different times during the respiratory cycle, and they called it different things: APRV, bilevel, PVRC, there's high frequency. Well, when they looked at the sickest group of patients, none of the ventilator strategies worked. And we tried all sorts of different types of ventilator strategies, and they still had very high death rates. So ECMO comes along, and it allows you to actually go back to a normal physiology, rest the lungs, put in a big cannula, drain blood from one vein, put it through a centrifugal pump, push it through a membrane lung that very efficiently exchanges gas, return it to another large vein. We return it to the right side of the heart, drain it usually from the hepatic IVC, and we can completely take care of gas exchange. And that allows us to turn the ventilator support down. It's not a treatment for the lungs, but it lets the lungs rest. I think if I get sick, put me right on ECMO. You can skip the ventilator. And I came up through pulmonary, so I came up through ventilators and was all into the advanced ventilators. And I got into it just kind of by accident 15 years ago because I was in Germany taking care of our soldiers coming back from Afghanistan and Iraq, and they had another level of lung injury. They got blown up, bounced around, inhalation injury, blast injury, thermal injury, lots of blood, lots of surgery, trauma, and then paralyzed and sent to us on a 8-hour flight or 12-hour flight, depending if they were in Afghanistan or Iraq. And what happened? Their lungs, there was another level of lung injury. And we did all the things normally to do with evidence-based lung protection, paralysis, proning. Then we do all the rescue therapies with APRV, high frequency. Again, different ways of delivering positive pressure to the lungs, calling it fancy stuff and using fancy computer algorithms to determine how the pressure is delivered. But it's just a different way of delivering more pressure to lungs that naturally are a negative pressure system. So did it work? No, didn't work. But you have a 22-year-old who's dying, and ARDS and trauma, you guys may not know, but it's that those guys do the best. So lung failure from trauma, and it makes sense, they do better than lung failure, say, from pneumonia or from pancreatitis. So we knew if we could support them for a week or so, they would do well. Well, down the road were the Germans at Regensburg, who were had one of the best ECMO programs in the world at the time, still do, and they were developing the prototype of the CardioHelp, which is what we're using today. And I still remember it was in November of 2008, they came over and put someone on for us, and then they would put them on and then take them back to their hospital in Regensburg, and eventually we became friends with them and went over, and I lived in the Regensburg hospital in Germany for a while. They taught us ECMO, and they're about 10 years ahead of us. One nurse would take care of 3 ECMO patients, which is, Dr. Spear will appreciate that, because they're advanced and they've been doing it a long time. So that's how I got into it in the short story. Why I think it works here in COVID is, well, if they fail lung protection, paralysis, and proning, and they're otherwise healthy, then we put them on right away on VV ECMO. We ran higher than normal levels of anticoagulation, because you guys have probably all read about the thrombotic microangiopathy that attends COVID. So these guys clot more than any other group I've ever seen. And they clot in spite of being on heparin. We had situations where we gave a heparin bolus and Ramesh was cannulating and the cannula was filled up with clot, even after getting 5,000 units of heparin, and we give another 5,000 and the guy's still clotting. I think our success has been, the most important thing is patient selection. After that is higher levels of anticoagulation, and then being adequately resourced in terms of staffing. And we didn't get overwhelmed. Like my friends at Columbia, they have one of the best programs in the world in terms of ECMO, and they do like 100 VV ECMOs a year, but their ECMO docs were managing entire units of patients on vents. So they didn't have the ability to take care of, 30 ECMO patients that were just on ECMO. They had to take care of a larger group of patients and got overwhelmed. I guess that's a little bit of an overview. I can stop for questions.
Eric, you said that this patient selection is important. Do you have an algorithm, a score system? How do you go about select? Of course, I'm sure age probably is a factor, but what is it that you, is there a team decision? Can you elaborate on how these patients get selected?
Sure, that's the most important thing. We spent a lot of time talking with Dr. Spear and the surgeons and the other ECMO docs, respiratory failure docs. Our age less than 60, no significant comorbidities, no chronic renal failure, no chronic heart failure, no chronic lung failure. So age less than 60, a P to F ratio, so that's the partial pressure of oxygen divided by the oxygen from the ventilator, the fractional inspired oxygen. And that's a pretty accurate marker of disease severity for ARDS patients. Your P to F ratio less than 300 is mild ARDS, less than 200 is moderate, and less than 100 is severe ARDS. And when they looked at 5,000 patients that all had ARDS, that was the one single variable that stood out among the others. They looked at compliance and X-ray and how much ventilator support you were on, but that one P to F ratio was predictive of who was going to survive and who was not going to survive, and how severe their ARDS was. So we use a P to F ratio less than 100. For example, if I was to do your P to F ratio and put you on 100% oxygen, your P to F ratio would be 400 to 500 because we're breathing 21%, and a lot of these patients are getting 100% oxygen on the ventilator or more. So we look at the P to F ratio, age, and then they have to fail the other proven. Paralysis has been shown to improve survival by about 9%. Proning has been shown to improve survival in multiple pretty well-designed randomized controlled trials by 17%. 17%, just flipping someone over. And that's pretty impressive. And it's good data, and it works, and it especially works in the COVID population. So that they have to be protected, and that's low volume, low pressure. And we'll back up again. Your tidal volume is less than 6 cc's per kilogram of ideal body weight. And that comes out of, as you guys are sitting there breathing, listening, trying to stay awake, your tidal volume you're taking right now, your normal resting tidal volume is about 6 cc's per kilogram of ideal body weight. So it's not very much, actually. You have someone who's 70 kilograms, it's going to be 400 cc's. That's just sort of resting as they're breathing in and out. And when the lungs get really sick, they fill up with fluid and they collapse and they fill up with proteinaceous material and inflammatory stuff. So you get really even smaller than 6 cc's is what your resting tidal volume is. If you try to give normal tidal volumes or big tidal volumes, you're going to overstretch the good lungs and hurt, cause more problems. So we do low volume, low pressure, and the plateau pressure we can measure. It's a surrogate measure for your static lung compliance and how much pressure, what's the force that the lung tissue is seeing from the ventilator. If that's above 30, then we know it's causing harm. So that's protection. They have to fail lung protection, fail paralysis, and then fail proning, meaning you can't keep their SATs above 88%, or you can't keep their carbon dioxide below 65, meaning you can't achieve adequate gas exchange, giving them protective settings on the ventilator and doing the normal things. And if you fail that, and we cause failing that, 2 hours of not doing well, or your PDF ratio being below 100, and you meet the other criteria that you're otherwise pretty healthy aside from having your lungs go beat down from COVID, then you're a candidate.
And what is the average days that these patients have been on? What was the longest one? And is there a point where you've had a patient that, or do you have an end game if patient is not getting better? Or have you had that scenario?
We've been fortunate enough that we haven't had that scenario yet. We still have a couple patients that are in their 4th week now that just the lungs didn't get better. Our average length of stay is probably about 10 days, so 1 to 2 weeks, which I thought it was going to be longer based on our experience with H1N1, and then the experience what we heard from other institutions over in Europe and China and Japan. Our shortest has been 3 or 4 days, and then the longest, I think we had a guy on VV for 21 days, and then he was on VAV for another 5 days. So he was on for almost a month, so 27 days, and then he came off. There's a couple people that are still on, and they've been on a long time. That's a hard one because I'm in a chat group with ECMO programs all around the world, and there are lots of reports of guys at 4, 5, 6 weeks getting better. So unless they have something irreversible, big head bleed, or the heart goes down, or they have multi-organ failure, we've been fortunate enough to be able to keep going because we've had enough machines and we've had the resources. If we max out our machines and you have someone who's been on for a month, and then we're missing all these other patients and having to say no, that's a tricky ethical decision, and we'll meet as a group and discuss that. And we're coming up on that on a couple of our patients now, where we fill up and have to say no to people that are going to be on your normal 1 to 2 week run. Is it justified to have someone on for 6 weeks who maybe is likely going to die, and you're using that machine that you could use on 3 people that are going to be able to actually survive and do really well? And like I said, we're looking at going for an 80% survival. We're not going to publicize that yet until we know it for sure, but I think we're going to be close, actually. And again, it's patient selection and then having a well-resourced team.
I mean, kudos to you guys. I mean, it seems like you've done it really well by patient selection. I mean, 80% is amazing. And at the same time, the resources were never in question as far as I can tell. And now that surgery is coming back on and patients are being treated for the usual stuff that we treat, it seems like resources was never in question. Are the numbers, well, 2 questions. First, you were seeing a lot of younger patients that they go on ECMO. Is there a common factor in who gets this sick at a younger age that you've seen? I mean, I know obesity is talked about quite a bit. And then how are the numbers? Are you guys doing as many ECMOs now than, let's say, a few weeks ago, or the numbers are waning as the cases are waning?
The first question, in terms of risk factors, 80 to 90% of our patients have been Hispanic that have been the sickest. So there's a clear ethnic or racial predilection. And then in the ones that are in their 40s and 50s, high level of BMI above 30, high level of hypertension, high level of diabetes. In the younger kids, we've had three teenagers, 2 were obese, 1 had asthma. The other young 24-year-old had a renal disease. She actually got better pretty quickly. So obesity was still the main factor. We have not, even though the numbers of new cases and the numbers of admissions have been going down, people are still entering the hospital faster than they're leaving the hospital. And then that subset of patients who's critically ill, it takes them a while to get ill. So they're in the hospital on the wards and they get sick and they go down to the ICU, then they get intubated and they're intubated for a couple of days. And then the young, healthy ones that don't do well on ventilators get put on ECMO. So our numbers are still high. I mean, we've got 7 COVID ECMO patients now. And I will back up and say we have been limited by resources just because we have a finite number of ECMO beds and a finite number of ECMO machines. We've had to say no to a lot of people along the way. And I'll tell you, the hours have been tough, but that's nothing compared to I guess it's a sort of an emotional challenge of saying no to patients, people other intensivists that I know and I've been working with for years, and they call and say, hey, I got this 44-year-old, he's dying, a little heavy, but otherwise healthy. He failed lung protection, we paralyzed him, we proned him, and he's sitting in the 70s and his PDEF ratio is below 100. So a candidate for ECMO, and we have to say, listen, we don't have the beds or we don't have the machines depending on what's going on with us. So we have had to say no to a number of people, and that's just the nature of a pandemic where you have limited resources and limited capabilities. I did get, we were limited, not so much by physicians and machines. Dr. Spear did a great job of advocating for we have a lot of machines, and we've been kind of cagey about, well, how many people could you put on max? That's a loaded question because it depends on, the limiting factor really is nurses and beds. And we just ran out of nurses. And in the military, we just tell a nurse, listen, you're taking 1 patient, tonight you're taking 2 and you're gonna do what I say. And they'll get upset, but they're gonna follow orders. And that's what I'm used to. You can't do that with you can't do that with the civilian nurses, not in the same way. So we've had to be compromised and recognize we're limited as an institution. And that balance of, well, we can stretch ourselves, but as we stretch, the standard of care drops. And that's already happened for us. And we've been fortunate, we still have had really good outcomes. But we're kind of, eventually luck runs out. So we've had to what we've done now is recognize this is going to be a long-term process, and we need to kind of consolidate our ECMO in one area. We were trying to run ECMO in both the CVICU and med-surg, and that was just too much because we had to run ECMO in 2 places. You have to have we had an ECMO doc in both. We were doing a lot of extra shifts. Now we're going to have an overflow down into the CICU if we run out of beds in the CVICU, or if we need beds upstairs for surgical patients, we'll be able to move them down to the CICU.
That's amazing. I certainly didn't realize that you had to make these tough decisions, and it is very difficult to say no to a young person who otherwise will not survive. Is there any thought as if we truly have a second surge come this winter, is there any planning or thought to have more resources, train more nurses, expand the beds somehow?
I think we're working on that. We certainly have a population now of nurses in the med-surg ICU that are ECMO qualified. So we've really expanded, and we've used a lot of our APPs and the CT surgery PAs who didn't usually take care of ECMO patients, VV ECMO. The lung failure was usually taken care of by the APPs on the medical side. The surgical PAs stepped up, and they've been able to take care of the lung failure patients on ECMO at night, which has been really helpful. And they've expanded their scope of practice to include VV ECMO, which has been great. So we do have a higher number. It's really going to come down to how many beds are we willing as an institution to use, because you've got to maintain your cardiac surgery. You're going to have to maintain our shock program. You guys are going to need beds for your STEMIs and for your complex PCIs. So that's a tricky balance. I did present last night at there was a leadership forum. Our end project was, an additional 24 ICU beds in IHVI. So that's a long way off, and that's a lot of hiring a lot of nurses, doctors, additional surgeons, additional cardiologists. But that would be the dream, 5 years ahead. We'll have 24 more ICU beds, and then we'll be able to fill that up in time. The patients are out there, and the lives are out there to save if we're able to get the resources and the beds and the people.
Can I just weigh in 1 second, Eric? And just
Sure.
I think Sean, you've asked some excellent questions, and the real issue is how. And I think that probably if you were externally looking at this with the criticism about the appropriateness criteria, this was all designed by looking at our last several years of VV ECMO patients and taking all those things into consideration. The one additional thing that we use pretty stringently is that the patients are intubated a week or less. Many of the patients that Eric's referring to have been intubated for 2, 3, 4 weeks, and then they fail that. And those patients haven't survived. The other thing that the NOVA did that was fantastic was that all of the ICUs have negative pressure flow in them. So it's our hope. We've got to renovate the CVICU. We'll move up to the 3rd floor. That'll be the new CVICU. And then, as Eric is alluding to, it's our hope that we'll have now expanded to 3 units in the Heart Institute that would be capable of handling advanced therapies, both for VA and VV. And we're training our CICU nurses at the same time, our MSICU nurses and the CVICU nurses to have been trained to have a backlog. So we're hopeful in this expansion that Eric's alluding to, that given the resources that we've had from our fixed structure ICUs, from our number of machines that we have available, which is between 20 and 25, our great ECMO therapists and our physician resources with Eric Mahul Desai, Jim Lantry, Chris King, and then we're looking to bring in 3 other MCCS ECMO specialists with the surgeons, with the APPs, that we'll be able to accommodate this rapidly expanding and growing group of patients. The one real problem, as we all know, is the extraordinary impact that COVID had on the resources for the institution. When you're losing $100 million a month, being able to use this to expand therapies rather than recoup back to where we were is extraordinary. So it's time's going to tell as to how this is going to work out and what the prioritization will be. So as Eric's alluded to, being the only quaternary program in Northern Virginia, we're going to be balancing the rapidly expanding hemodynamic population of patients with our shock program, the cardiac surgery program, with our ECMO program. So on any given day, today's a case in point where Eric and I are talking. I talk more of as much to Eric as I almost do to my wife. All of us are talking all the time. And one of the unintended consequences has been this improved communication, collapse in the silos among the units, shifting the nurses and the APPs, and truly not looking at the silos that the Heart Institute might be 50 miles away. So I don't mean to pirate the conversation, but just to tell you what we've learned in a pandemic will, I think, have very real and rich improvements in our collaboration. I mean, these are great guys. We couldn't have appreciated, enjoyed the relationship more. But we're into the 3.5. We're into, this started on March the 3rd is when this started. One of the things that Eric in his humility didn't say is we're killing our doctors. Our APPs have taken 480 additional shifts. Eric has been on call along with his colleagues for 3.5 months with almost no break. The same with a lot of our nurses. And it's not sustainable. By having them all back in the ICU, in the Heart Institute, we at least have patients above each other on 2 separate floors rather than 500 yards away. We have to give them a break. We have to expand the therapy. And so our resources are stretched to the max. So yes, we're seeing, decreased numbers. We had 123 patients today versus 350, but our ICUs are over 90% occupied. So I don't mean to be so long-winded, but there's a lot of ways we're thinking about this that are not at all how we thought about it before.
No, thank you, Alan, for that. Your thoughts. I think, you guys have been amazing. This pandemic sort of happened, so fast, and nobody was ready for it. And given that fact, you guys at Innova have done a tremendous job. For us who are not in the front line, coming to the hospital, we really don't see it because, you're secluded in those COVID units. But these 80% survival is amazing. And I'm sure everything had to be stretched, to achieve that. And, there's no words can really express the gratitude that we all have and the society has for, you guys. Anybody has any questions?
I have a question.
Hamid?
I've got one.
I can ask a question, but I see Eugene is on the screen right now. Go ahead.
No, Eric, I was curious. You said earlier about the thrombotic complications from COVID that we've all heard about, and the aggressive anticoagulation you're doing. How do you balance that with the known bleeding risks and complications of patients being on ECMO? What's your strategy there?
I tell you, the one thing that gives me nightmares in ECMO patients is head bleeds. Because what do? You can't do anything. You can fix everything else, and then normally I'm military. You don't die of blood loss. You can replace blood unless you're bleeding into your head. So, and we were very concerned about it because H1N1 had a very high rate of head bleeds. The mixture of the viral cytopathic effect on the neurons mixed with heparin and the very deep coagulopathy that occurs from being on ECMO for days to weeks. The RPMs are anywhere from 2,500 to 3,500. So 3,500 revolutions per minute in a centrifugal pump. That's not physiologic. So the blood gets beat up, the platelets get beat up. You're going through a membrane that's a non-biologic surface. It does get coated with your own cells right away, but the depth of the coagulopathy is much deeper than just being on heparin. So yes, they bleed, and it's been a problem. We have not seen bleeding problems in this patient population. Yeah, we've had a few people that had GI bleeds or had some cannula site bleeding, but I have been amazed. Like I already said, this group has been more thrombotic than any group of patients I've seen in my 24 years. I'm an old guy now of practice. They're not bleeding. And the bleeding we've seen has been from guys that were giving TPA. We have given TPA now to 7 patients and this is treatment dose TPA. Some of them are on heparin, they're on bivalve, and they're having PEs, or what we think is a PE, or they have acute right heart failure, they get tachypnic, tachycardic, hypoxic. You take a look at their heart and they've got a McConnell sign and the right heart is suddenly blown out. You give them a bolus of TPA and they get better. That's happened now multiple times. And then you follow it up with a TPA infusion on bivalve. So this is like crazy. I hadn't, until like a month ago, I'd never done this, a month and a half ago now. But we've done it now multiple times and it seems to have helped. We had one guy clot off his entire leg of the venous system and he got TPA and then a TPA infusion and then a thrombectomy through our friends in IR, and he's walking now. Now he was a Coast Guard Special Forces guy and was pretty motivated, but he's walking, and I just talked to him today and he's not having pain, which is amazing. Like I don't know if he just is insensate or so. They haven't bled, and we've just been pushing more and more. The big thing we've done is we're not stopping the bivalve, you're not stopping the heparin unless it's life-threatening bleeding. Once they come off of ECMO, we're keeping it going because I talked to my friends in Paris and Germany, and they were seeing PEs in their survivors right after they came off, or when they're leaving the hospital, guys were dying of pulmonary embolism, like 20%. And that was a legitimate case series. So we're keeping them on bivalve for 4 days, therapeutic dose. We come down a little bit, but IV bivalve, and then we switching them to Eliquis for 3 months, and then sending them out on Eliquis because the risk of bleeding is small in a healthy guy. Dr. Spear?
Yeah, I think the other point that was made when you looked at the experience in both China and in Italy, they had a 30% myocarditis association. And there are two things that were done. And the one is, I'm not sure that the myocarditis was actually with the right-sided failure, wasn't subendocardial thrombus from exactly what we're talking about, this microscopic thrombosis that has just never been seen before. And it's both the stroke rate in the younger population as well as this the COVID toes, with the large vessels open and the microscopic circulation thrombosin. But that's made a huge difference. And the other thing, to Eric's credit, he was very aggressive in implementing the CRRT with our whole population of patients, and with the cytokine removal, and it made a huge difference. Could we measure it? No, but we were seeing the recovery of both ventricles that were not being seen other places. And so I think that there are these subtle things that we have to go back and look at and break down. But the proning of a patient on ECMO, it takes 6 nurses to turn. I mean, you've got all these cannulas, and many of them are CRT, and they're on these pumps. But proning them improved them. It absolutely improved them. And so by talking to our colleagues, we said, oh yeah, I mean, many of us in our hospital system didn't prone anybody. So this has been a big learning as well. But I think that the thrombosis rate, we're all going to look back and wonder what was that? How do we diagnose it better, and how do we treat it better?
So I have a question. Eric, thank you for the nice summary. Do you have any experience with patients with COVID and require ECMO and Impella or something to help the LV side? And I was going to ask you about a patient we had and was turned down for ECMO at Fairfax.
So you cut out for a little bit. You're asking if we had to use Impella. So we've had, I think, 5 patients go on some version of VA ECMO, either VVA or VAV. Most of the time it's been for right heart failure. We've had a couple of biventricular failure patients, and both of the ones that had biventricular failure, once the heart went down, it was the craziest thing. That the troponins didn't go up, heart went down, stayed down. Troponins didn't go up, but then they went into multi-organ failure, and that one guy was 45, the other guy was 50, and they both died pretty quickly in spite of being on VA ECMO. Both of them had maintained some pulsatility. For most of it, we were able to use epi to keep pulsatility and did not need an Impella. certainly if we had someone who needed one, we would ask for it, and that's an effective way that we've vented patients before. We haven't had the chance to use it. We did say, going back to the patient I think you're referring to, is that we weren't going to crash on to VA ECMO in this patient population, given, and then again, this is combat medicine. You've got to pick the people that have a high chance of survival. We can put anybody on ECMO, but the ones you crash on, their mortality is 80%, and you compare that to what we're hoping is going to be an 80% survival. Would you use your machine on someone who's most likely going to die, or do you use it on someone who's more likely to live? And I get it, that's very hard if you're the doc and it's your patient. You don't want to hear that. And I still, I went to the bank yesterday, and the teller at the bank was, somehow she found out I was a doc, and then I asked about, she said, oh, my husband is in Woodbridge Cemetery. He's 42 years old. He's been on the vent for 40 days, and he had a stroke. They stopped heparin, he had a stroke, and he's really sick. Turns out they called me about him about a month ago when he was 14 days in, and I said no to ECMO. What happened last night was he coded and died. And what do you do? I mean, you do the best you can, but that's a loss. And if we were, if we had unlimited resources, that's a tough one, and I'm going to go and see her tomorrow. What do you say? Because I did say, listen, we've had good luck with ECMO. I said we try to put him on with, 7 to 10 days. And when they called me, he had been on, for too long. So we said no. I don't remember the patient you're referring to.
It was a young patient who had biventricular failure and was getting really sick acutely. And so it was turned down, but fortunately, I think GW took on this patient, and patient is being discharged. So we are happy that the 23-year-old survived. But I think the comment we heard is that this biventricular failure, acute myocarditis don't do well, and that's why they didn't take him. But now, at least as a case report, these patients can actually do well if they are given the right support. But a second question for you is, do you have any experience with interleukin-6 inhibitors in these patients?
So tocilizumab and solizumab, yeah, a lot of our guys have been on it. I don't know if they work. It's too early to say. I know the people that got tocilizumab have high rates of infection. I know the people that got remdesivir, I know that it will slow down viral replication. I don't know that in the sickest patients it really does much. I think it's critical care and time, and then giving them freedom from further injury so that they can heal on their own. The IL-6 it's still too early to know. It did not seem to have done very much, because a lot of the ones that got the IL-6 inhibitors ended up progressing to ECMO, and again, a lot of them have done well. The patient you're talking about, the 20, that's amazing. That I'm delighted that she did well. I did hear Paul Clark was on, and that was another one. He's like my friend from the Army. We tried to get him to come work for us here, and Hospital Center paid him over $500,000, which is pretty good for an intensivist. You guys all probably make more being high-flying cardiologists. But we were short on beds. So it comes down, and that day, if we had multiple open beds, we might have taken a chance on someone that young. But if you're down to your last couple of ECMO beds, we need it for the cardiac surgery patient that might need it, or we need it for our shock patient in-house. You have to maintain the capability for your in-house emergencies, or, what if I go down and need it? I mean, it's kind of being tongue-in-cheek, but your criteria and the ethics of this are actually solid. Your criteria has to get even tighter as you come down to your last couple of beds. If we're going to support 7 people on ECMO, you need to be able to support them well and have backup machines. And so GW was not busy, so they had the time and the machines and the bed, and thankfully that she did really well. I'm happy to hear that.
Thanks, Eric. I think Mehrdad is asking to, has his hands up. So Mehrdad, go ahead, please.
Well, I also want to thank Eric and Alan for all the hard work and what hardship they go through to take care of this very ill patient and provide a great service to the community. It seems to me that the practice of medicine and management of patient in a matter of few weeks has completely changed. The way we are taking care of the patient as outpatient, how we use technology, I don't think we should ever go back to, the old normal. We have learned so much. I was wondering in a critical care patient, how do you see the critical care and management of patient with shock, and just how can we make this more cost effective in the future? What are some of the lessons that we have learned through this crisis that we are going to carry and change the care of patient in critical care needs?
Those are excellent questions. And yeah, Dr. Spear and I are here today, but there's two of us. It's really to go each ECMO patient that has done well. It's really been hundreds of people. It has to be a system behind it. The nurses, the ECMO specialists, the RTs, all the other doctors, all the other surgeons. It's really a team approach. And that leads into the answer to your question. We've realized how much stronger we are and more effective we are if we're able to work in teams. And like Alan was saying earlier, breaking down the walls and working really closely. One of the unique things about our ECMO program is we're very close and work closely with the cardiac surgeons, and that just amplifies. As in the military, it's a combat force multiplier. 2 + 2 = 4, and instead of 5 instead of 4. So it shows us the value of teamwork, which is obviously a cliche but true. I think moving forward, it shows us. I think ECMO is going to expand, and it shows us the value of patient selection, and it shows you how much more you can, by consolidating resources, how much more you can do and how you can stretch yourselves in a safe fashion. I know it's changed a lot. I think it's going to stay changed, and I think COVID is going to be here for a long time.
Merdad, I think your question goes to really how all of us will come together and make these decisions for the greater good. It really has so many ethical implications, moral implications, financial implications, and societal implications, because as Hamid brought up that patient, what we did was we have a collaborative and consortium where, with the hospital center and Maryland, Johns Hopkins, GW, and us, and it was truly looking at how can all those shared resources collaborate better and be able to move these patients between and among the institutions in ways we've never even considered before. That's the first point. The second is really each of us are involved with that individual patient and what's the greater good for that individual. But what we learned for the first time is we were limited. It was, and the only thing that's worse than deciding who not to put on is then taking somebody off prematurely or at a time when we feel like if we just go a little bit longer, they'll get better. And, it involved several of us putting a whole ethics team around the limited resource ethics team. And there's one for the system that some of you know about, where there was a course and a whole collaborative around ventilator withdrawal, around some of our other devices, but specifically there was one for ECMO, that if we got to a place and somebody needed to go on and this patient for 4 or 5 weeks was not going to get better, we had to make that tragic decision to take them off. So beginning to have it, so now when patients are put on ECMO for COVID, they're told at the inception, and this is often fallen to to Eric and his colleagues. We are going to see how they do for a period of time, and then the decision will be made as to whether or not this is sustainable. So beginning to have these conversations between and among ourselves and within the communities of our patients, where we will include them at the inception, but will it be as open-ended? You know, will we be able to do this for an unlimited period of time? And so I think that we're going to see less resources, not more. We're going to see more collaboration around appropriateness criteria than we've ever seen before. And the final thing, and then I'll stop, is that we're going to have to use the data in ways we really never used it before to decide who will benefit and who.
We're losing your audio.
So anyway, is that better? Sorry. So I think the data needs to drive what we do and how we do it. So I don't think I answered it to your satisfaction, but it's as well as we're still learning.
Thank you.
That's great. I think definitely collaboration is key, and knowing from structural heart program, it's always better when different specialties get together and come up with algorithms and use different experiences to advance and better care. It's hard to believe it's already 1 hour. So I want to thank you both for taking time to come and be with us and let us give us a window of what's going on in very sick patients you're dealing with COVID. Hamid, did you have a last question you wanted to ask?
No, I just wanted to thank both of our speakers. Thank you.
Thank you very much, folks, and be safe.
Thanks for having us. And I would add briefly, in the old days, our consent included a 2-week time limit. So we said, we're going to go for 2 weeks. If they're not better, we're just going to stop. It wasn't a discussion. It wasn't a meeting. You just stopped. And then we figured out, well, if you have the resources to keep them on, you keep them on, and actually you'll be surprised. The lungs have a regenerative capacity that we didn't even know existed because we stopped earlier. But like Dr. Spear was saying, we're going to have to make some difficult decisions moving forward. And now in a non-pandemic, I have seen patients after 4 and 5 months of EV ECMO get better and walk out of the hospital. So it's rare, but it happens. And when it happens, you see that happen to a 30-year-old or 25-year-old soldier. See it happen a couple of times, and it gets harder to off because people recover late. And I'm still surprised some of the recovery. We had a flu patient who was just on for 5 weeks, and we were talking about withdrawing, and then we started proning her, and she's now at home riding her bicycle, and just sent me a picture of her riding her bike and playing with her kids. And that's why we practice medicine.
That's wonderful. Thank you very much, folks.
Thank you so much.